Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back William Lynes. He's a urologist, and today's Kevin MD article is titled Quitting Medicine, a Disgraced Survivor of a Bloody Suicide Attempt. William, welcome back to the show.
Hey, thank you, Kevin. Thanks for having me.
So, William's been on many times on the podcast by Kevin MD. Just go to kevinmd.com/podcast. Upper right-hand corner, there's a search icon. Click on that, and you could look up William's prior episodes to hear his story. But today, I want to get right into this Kevin MD article. It was published back in 2019, but it really resonated with the audience. Got over 18,000 shares. It's titled "Quitting Medicine: A Disgraced Survivor of a Bloody Suicide Attempt." William, tell us how this article came together.
Well, let me just say that in addition to being a physician, a urologist, I'm also a survivor of multiple suicide attempts. And what we're talking about today is I call it the note, which is basically a note that nurse handed me that a patient wanted me to read before an appointment that I had with him. And just briefly, I started practicing urology in 1987. And I retired after a suicide attempt in 2003. And during that 16-year period, about in the middle in 1998, I had two catastrophic medical illnesses, one being septic shock with intensive care unit visit for 6 weeks on a ventilator with a tracheostomy and so forth, and very, very sick. And I lost 40 pounds. And then just right after that, I had a snowboarding accident with, again, an intensive care unit visit and a 40-pound weight loss and so forth. Anyway, these two events were very significant in my life because when I went back to work, I really was never the same. And I found out that I had a bipolar affective mood disorder. I was suffering from physician burnout and severe depression, anxiety, and so on. And I began in 1998 what I call a downward spiral into darkness, which is sort of code for suicidal behavior. And my practice culminated it was September of 2003 after a suicide attempt. Now, the patient that we're talking about, I'm going to call him Mr. Smith. He was a patient who, and this happened a couple of months before I retired from medicine. So we're saying in the summer of 2003. He was a longtime patient of mine. I had actually been seeing him since he was 72 in 14 years before this event. And he had two urologic problems. He had recurrent low-grade stage transitional cell carcinomas of the bladder, which required transurethral resection on multiple occasions and intravesical chemotherapy. And he did well from that. But I also picked up that he had a localized prostate cancer, which is extremely common at the age of 70. And specifically in regard to the prostate cancer, we elected, because of his bladder tumors and because of his age at the time, being 72, we elected to just observe the prostate cancer. He lived, however, a long, productive life. And it was fast forward 14 years later when he was 86 years old. He had developed, the prostate cancer had progressed, and he had developed widespread bone metastases from castrate-resistant prostate cancer. And he also had a problem with local prostate cancer disease in the prostate. And he required me to do a transurethral resection of the prostate on multiple occasions because of recurrent bleeding and urinary obstruction. And he was coming to me for a preoperative exam for another one of these transurethral resections. And he handed the nurse a note and said, "Dr. Lynes, I want Dr. Lynes to read this before he sees me." And of course, so I looked at it. And it was interesting. It was a postcard written in very beautiful handwriting. I remember it had the flowery border around the outside. And I should say that, as I recall, he was in the journalism field, and he really knew how to write type. Really knew how to capture my attention, because what he said was, "You are a devious, underhanded character." The perfectly scroll writing went on. And he went on then to accuse me further of saying, how could you neglect my disease? So I was shocked, but I read on and it got worse. Sort of the grand finale, it was really a betrayal to me, wounded me deeply, because after I had taken care of him for 14 years, he said, I know you really did not do those operations. Now, at the time, I was a couple of months away from a suicide attempt and retirement. And I was not in mental shape that I would have been at some other time in my career. And I don't want to say I flipped out, but I was really, really, really upset. And I remember telling the nurse that that Mr. Smith's surgery was canceled. I walked across the hallway and talked to one of my colleagues about him and referred Mr. Smith to him so that somebody else could take care of him. So that's the situation with the note. Fast forward a little bit in his care. He had widespread bony metastases from prostate cancer. I knew that, but it eventually was proven that he had some brain metastases as well from prostate cancer. And it's actually ironic because the very first peer-reviewed journal article that I wrote as a Stanford urology resident was on brain metastases from prostate cancer. So in retrospect, there was really something wrong with the thinking of this patient. But he wrote a beautiful script to me and was able to communicate. And I had a long time relationship with him. But that's the story behind
Sure.
this article.
So you said that you had a 14-year relationship with this patient.
Yes.
Could you have seen any of this coming from your prior interactions with him?
Absolutely not. I had a very good, what I thought was a very good relationship with him. Never had any paranoid type of interactions with him. And it's so clear now that there was something medically wrong with his thinking. But at the time in my mental illness, I really just sort of took it personal and, didn't really put it all together.
So the fact that he had brain metastases that may have disrupted his thought processes, now that you reflect on it and you've had the benefit of time, does that change the impact of his note?
It does a little bit. I think that at the time, I was really in bad shape, and I didn't appreciate it at that time. But as I look back, I forgive him more so, and it all makes sense. Brain metastases from prostate cancer are very, very unusual. That's why I wrote the paper. They unfortunately are in terminal individuals. Everybody who has them dies. There really isn't treatment, though people do give radiation therapy for palliative effects. But yeah, I forgive him and I understand better now.
What kind of messages can physicians today learn from your story? Because I'm sure that sometimes they do get notes from patients who are dissatisfied with their care, and it could be influenced by
Yes.
brain pathology or not. But what kind of messages can you share with clinicians who may receive similar notes from their patients who may
Right.
be dissatisfied with their care?
I think that you need to take a step back when you get a note from a patient or through other channels, have some understanding that they are unhappy with your care. Try to look at it from their standpoint. In this case, there was a medical associated reason for his sort of bizarre thought processes, and other people may be in that situation as well, or it may be just that they are unhappy with their medical course and are blaming the physician. But I guess the main thing would be to step back, take a deep breath, and try to look at it from the patient's standpoint.
So at that moment, and I know that you had other behavioral issues going on at that time, did you have anyone to talk to about this? Did you have anyone to help you take that step back in terms of processing something like this? Tell us what kind of support systems you had at that time.
Well, I had really sort of unusual in that I had a psychiatrist who I had been seeing since my septic shock days, 1998. So I'd been seeing him for, I don't know, 6, 7 years. And he had always been, very helpful with me. I'm not sure I talked to him at that time, but I could have. As far as the medical community, not really. And I blame myself really for that, in that I didn't reach out to people. I have a dear friend who tried to reach out to me, but I sort of rejected his trials of trying to help me. So beyond my psychiatrist, I did not. And I think that that's very typical of people in the middle of mental illness and physician burnout, is that you feel alone, you feel embarrassed, so embarrassed, and you don't want to burden your already overburdened colleague.
So when you say take a step back whenever a clinician receives a note like this or receives some feedback that the patient is dissatisfied, let's go into more detail. What exactly do you mean by that? What kind of questions should that clinician ask themselves? What kind of things can they do to proverbially step back?
Well, I think you need to review what's been going on in the care of the patient. The patient has very specific knowledge of what's going on. You may have a sort of a cloudy view of what's been going on. I mean, I knew this patient very well, but I should have stepped back and reviewed, what was going on. I think you do physically, you should actually take a moment of time out, actually, and ask what's going on with the patient. What did I do to cause this? And what can I do to settle the situation? I think then you need to talk to the patient and try to come to mutual solution to the situation.
We're talking to William Lynes. He's a urologist. Today's Kevin MD article is titled Quitting Medicine, a Disgraced Survivor of a Bloody Suicide Attempt. William, tell us some of the take-home messages from this story that you want to share with the Kevin MD audience.
Well, physician burnout is a very common problem. 400 physicians in the United States commit suicide per year, almost all attributed to physician burnout. And you can do some quick calculations. If you say that 50 physicians attempt suicide per completed suicide and multiply 50 times 40, you come up with 20,000. And if you divide that by the number of physicians in the United States, it's actually 2.5% of all U.S. physicians attempt suicide per year. And I think that that's a harrowing statistic. And I think it's a real problem. And we could talk, I think we talk some time in the future about what my solutions are. But I think that the main cause of the physician burnout suicide problem is the deterioration of the patient-physician relationship.
William, once again, thank you so much for sharing your honesty, story, and insight. And thanks again for being on the show.
Thank you, Kevin.